Welcome back to The Deep Dive. This is the show where we take on some of the most, dense and authoritative medical texts, the ones you absolutely have to know, and we try to make them structured, memorable, and really clinically sticky.
And today, our mission is pretty high stakes.
Yeah.
We are diving into Chapter 28 of Baily and Love's 28th edition, which is dedicated entirely to traumatic brain injury, TBI.
Right. And we should be really clear from the outset. This deep dive is meant to be a kind of conceptual roadmap. Think of it as a ready reckoner for your revision.
Exactly. We're interpreting the core principles, we're trying to draw out the critical connections, and we'll be using, some memorable anchors to make sure these concepts are firmly in place before you go back to the source text.
So this is an interpretation, a guide. It is absolutely not a substitute for reading the full chapter.
Couldn't have said it better.
And the sheer magnitude of this topic, you really can't overstate it. TBI is not just some niche thing. It represents a huge global health crisis.
It really does. You're talking about an injury that makes up somewhere between 3 and 4% of all emergency department attendances in a place like the UK.
But the really tragic part is that TBI is the leading cause of death and disability, from childhood all the way up to early middle age.
The stats are just sobering. Long-term disability from TBI affects an estimated 2% of the entire U.S. population. And when you look at what's causing it, the mechanisms tell a story of really high-energy trauma.
Road traffic accidents are the big one, right?
They are, often up to 50% of cases. And that's followed pretty closely by falls and assault.
And we have to acknowledge that there's this massive variance in mechanism depending on where you are in the world.
Oh, absolutely. In the U.S., for instance, firearms are often cited as the third leading cause. But, regardless of how the trauma actually happens, the most critical distinction in managing TBI is what defines our entire approach to the patient.
And this is our first big anchor concept.
It is. We have to immediately separate primary injury from secondary injury. The primary injury is the irreversible damage. It's what happens at the exact moment of impact.
The contusions, the lacerations, the axonal shearing.
Exactly. And that, unfortunately, is a fixed loss. We can't go back in time and undo that immediate destruction.
Okay, so if that initial damage is done, it's a sunk cost, then every single thing we do acutely, from the roadside to the ICU, has to be about one thing.
Preventing the secondary injury.
Right.
Precisely. The secondary injury is the damage that develops over the next few hours and days. This is the harm caused by the systemic insults that we can actually treat.
Hypoxia, so lack of oxygen, hypotension, low blood pressure.
Inadequate perfusion, brain swelling. Our entire mission, what we're really talking about today, is how we manage the patient's physiology to shut down that secondary modifiable cascade of harm.
Okay, so that's the goal. Let's dive into the physiology that governs that whole process. So to stop that secondary injury, we first have to understand the brain's unique and frankly almost immediate needs. It's a metabolic powerhouse, isn't it? It demands this continuous high-volume flow of oxygen and glucose.
It is an absolute engine room. And the physiology of pressure and flow, it all hinges on one thing: cerebral blood flow, or CBF.
The brain is greedy.
Incredibly greedy. Normal CBF is extremely high. We're talking around 55 milliliters per minute for every 100 grams of brain tissue. If that flow gets interrupted or even just reduced, the brain goes from feast to famine very, very quickly.
Let's call that the danger zone threshold. At what point does the brain really start to suffer?
Well, ischemia, that's the struggle. It starts when CBF drops below 20 milliliters per minute per 100 grams. Once you hit that 20 mark, the cells are in trouble.
But if it goes lower?
If the flow drops significantly lower, say below 10, then cell membranes fail and you get irreversible tissue death infarction. It happens incredibly fast. You can think of it like a stroke, where the penumbra is that tissue getting just 10 to 20 LMEM. That's the tissue we're racing to save. In TBI, the entire brain is potentially in that penumbra.
And the physical force that's driving all of this flow is defined by a really fundamental relationship, cerebral perfusion pressure, or CPP.
This equation, CPP, it's essential. Not just for exams, but for every single decision that gets made in the ICU. CPP equals the mean arterial pressure, MAP, minus the intracranial pressure, or ICP.
So you can sort of visualize MAP as the force pushing blood into the skull.
Right, is the hydraulic force pushing in. And ICP is the pressure inside that skull pushing back against the inflow.
So it's a constant battle. If your MAP drops or your ICP rises, the CPP falls and your brain doesn't get enough blood.
That's the bottom line.
Okay, so in a healthy person, what are the normal numbers that give us that safety buffer?
A healthy MAP is usually somewhere between 90 and 110 millimeters of mercury. And a healthy resting ICP is very low, just 5 to 15.
Which gives us a nice healthy CPP.
It does. A healthy CPP is somewhere in the range of 75 to 105. There's a lot of reserve there.
But this is where the healthy brain has its own superpower, doesn't it? Cerebral autoregulation.
Huh.
And this is what changes completely in the trauma setting.
Oh, cerebral autoregulation is truly remarkable. In a normal person, if your blood pressure spikes, your MAP goes up. The little arterioles in your brain constrict to reduce the flow and protect the delicate capillaries.
And if your MAP drops?
They dilate, they open up to maintain that flow. It's this incredible intrinsic system that ensures your CBS stays constant, even if your systemic MAP is fluctuating wildly, usually between 50 and 150. The brain literally regulates its own supply.
But, and this is the critical point in TBI, that protective mechanism often just fails completely.
It does, especially in severe injury. Once TBI impairs or just obliterates autoregulation, the brain's blood flow becomes entirely pressure passive. It means CBF is now just linearly dependent on the systemic MAP. If the patient becomes hypotensive, brain perfusion plummets instantly. There's no backup system.
So the medical team, we have to become the backup system.
We are doing the job the brain can no longer do for itself. We have to aggressively manage both MAP and ICP to keep that CPP above 60.
That brings us perfectly to the structure that's housing this whole pressure system, the skull. And the concept that underpins all of this high ICP management, the Monroe-Kelly doctrine.
Right, which dates all the way back to the late 18th century. The doctrine basically states that the skull is a rigid box. It has a fixed, non-expandable volume.
Okay, and inside that box you have three main things.
Three primary non-compressible components: the brain tissue itself, the parenchyma, the intracranial blood, both arterial and venous, and the cerebrospinal fluid, the CSF.
Let's use an anchor for this. Let's make it stick. Think of the skull like a sealed, rigid glass bottle that's filled right to the very brim. There is zero extra space.
It's a great metaphor. Because if you try to add any extra volume into that fixed space, like an expanding hematoma, a big bruise, or just brain swelling, the contents have to shift. Something has to give.
So the body's first response is this compensation phase. What gets squeezed out of that glass bottle first?
The system is designed to compensate by getting rid of the most compressible or mobile things first. So first, the venous blood is squeezed out of the large venous sinuses. Second, CSF is shunted rapidly down the spinal canal.
And during this phase, you can actually add quite a bit of new volume, say from a bleed, without the pressure going up too much.
Exactly. If you look at the classic pressure volume curve during this compensation phase, the ICP rises really slowly, almost linearly. The system is buying time by shuffling things around.
But that capacity is finite. You can only squeeze so much CSF and venous blood out.
And that's the scary part. That's the transition to the decompensation phase. Once those mechanisms are exhausted, the system hits its compliance limit. It runs out of tricks.
And now, even a tiny bit of extra volume.
Even a tiny marginal extra volume, a little bit more bleeding, a slight increase in swelling results in an immediate, exponential, and frankly catastrophic rise in ICP. The pressure just skyrockets because there's nowhere left for the tissue to go.
Nowhere left to go except down.
Down, which leads to the ultimate medical disaster in TBI herniation.
That's the brain tissue physically shifting or herniating, pushing from a high-pressure zone to a low-pressure zone.
And we often see this catastrophe coming through some very specific, very ominous clinical signs. The one we see most often is uncal herniation.
Okay, that's the innermost part of the temporal lobe, the uncos.
Slipping over the edge of the tentorium cerebelli, yes. And the consequence we're looking for is compression of the third cranial nerve, the oculomotor nerve, as it runs right there.
And there's a key bit of anatomy here.
A critical bit of anatomy. The parasympathetic fibers that are responsible for making your pupil constrict run on the very outside of that third nerve. They're the first things to get squashed by that expanding uncos.
So when they get compressed, the sympathetic fibers take over unopposed.
Exactly. And that leads to the characteristic progression that we see at the bedside. Initially, the pupil on the same side as the bleed becomes sluggish in its response to light. Then very quickly it becomes fixed and fully dilated.
And that progression from sluggish to fixed is an emergency signal.
It's a siren going off. It's a high-priority, immediate signal for the surgical team.
But the compression doesn't stop there.
No, if it's left untreated, it progresses from the nerve to the midbrain itself. That leads to weakness on the opposite side of the body, hemiparesis, and then eventually severe posturing and loss of all brainstem reflexes.
The other, and perhaps most feared, form is tonsillar herniation. We often just call it cunning.
Tonsillar herniation is when the cerebellar tonsils are forced downward through the foramen magnum, the big hole at the base of the skull. This is instantly life-threatening because it physically compresses the control centers in the brainstem.
The centers that control breathing and blood pressure.
Your autonomous functions. Exactly.
And that rapid critical compression is what produces the classic historical sign of impending brainstem death, Cushing's triad.
We have to spend a moment on this triad because it is a massive red flag that demands immediate action. The three components are hypertension, a really high systolic blood pressure, bradycardia, a surprisingly slow heart rate, and irregular respiration.
What's so fascinating and so important to understand is that the slow heart rate, the bradycardia, isn't a heart problem, it's a brain problem.
It's a Burr receptor reflex.
Yeah.
The severe hypertension you see is the brainstem's last-ditch effort to maintain CPP.
Right.
It's forcing the MAP up high enough to overcome that sky-high ICP.
And the body's pressure sensors, the baroreceptors in the neck, they sense this massive, sudden hypertension.
And they trigger a powerful reflex vagal response, which results in that paradoxical bradycardia. If you see that pattern high MAP, low pulse, erratic breathing, you know you're witnessing extreme, imminent brainstem compromise.
Okay. Wow. This first section really does set the entire foundation for TBI care. Let's just quickly summarize the key takeaways. 1. CBF is delicate. We have to keep it above that 20 LMN 100 gram mark to stop irreversible ischemia. 2. In trauma, autoregulation fails, so we, the medical team, have to actively manage CPP to keep it above 60.
And 3, the Monroe-Kelly principle explains why small increases in volume suddenly lead to those catastrophic exponential rises in pressure. That's what drives the urgency.
Okay, let's do a quick conceptual check-in here. We just talked about Cushing's triad. So if your patient with a severe TBI suddenly develops extreme hypertension, say 190 over 110, and their heart rate drops to 55, is that a sign their heart is failing, or is it an alarm bell for their brainstem?
Think about why the body is generating that pressure and why the heart is slowing down. If you're struggling to connect those two, just take a moment and rewind. Revisit that brainstem compression and baroreceptor reflex before we move on to how we actually classify these injuries.
Okay, so we've seen the devastating potential of that uncontrolled pressure. But before we get to those end-stage signs, we need a standardized, reliable way to triage and communicate just how sick our patient is from the very beginning. And that brings us to the Glasgow Coma Scale, or GCS.
The GCS, it really is still the gold standard globally. It gives us an objective, repeatable measure of the severity of the head injury.
And it has huge prognostic value.
Immense.
Yep.
The GCS score, and particularly the motor component of that score, is the single best predictor we have for that patient's long-term neurological outcome.
Let's run through the sources categorization, which is based on the post-resuscitation GCS score. This is how we triage patients in the ED.
We classify severity into 4 main tiers. First, you have minor head injury. That's a GCS of 15 with no loss of consciousness.
Okay.
Then mild head injury, GCS 14 or 15, but this time with a history of a brief loss of consciousness or some post-traumatic amnesia.
Then we get more serious.
Right. Moderate head injury is a GCS of 9 to 13. These are patients who are significantly obtunded. They often need aggressive resuscitation and very close monitoring.
And finally, severe.
Severe head injury, GCS of 3 to 8. These patients are comatose. They need immediate intubation to protect their airway, and it signals a neurosurgical emergency.
And there's a huge caveat here, isn't there? Something that really complicates that immediate assessment.
Absolutely. The confounding factor of substances. Alcohol, recreational drugs, even high doses of sedatives given by the paramedics can artificially lower that GCS score.
Which creates a diagnostic dilemma.
It does. Is the low GCS because of the substance, or is it because of an acute expanding brain injury? And until you can prove otherwise, a patient with a low GCS must be treated as having a severe TBI requiring the full workup, regardless of intoxication.
Now, even in those seemingly stable patients, the GCS 14 or 15s, the mild category, we can't let our guard down. We have to be vigilant for the lucid interval.
This is the hidden threat. This is what catches the unwary clinician. The patient might have a brief LOC, they wake up, they talk normally, seem completely fine.
And
then they experience a delayed, rapid, and catastrophic neurological deterioration. This is the classic presentation of a rapidly expanding lesion, most often an extradural hematoma, which we'll get to in a bit.
And because of this risk, the decision to discharge a patient with a mild TBI is governed by really strict criteria, like the NICE guidelines in the UK.
The criteria for safe discharge are incredibly rigorous. The patient has to have a GCS of 15, no focal neurological deficits, a normal CT brain if one was indicated, and crucially, they can't be intoxicated.
And they can't go home alone.
They must be accompanied by a responsible adult who can actually observe them and bring them back to the hospital if needed.
And that adult needs clear written instructions on what to look for, right?
Right.
What are the warning signs?
The warnings are straightforward. A headache that gets worse despite simple painkillers, persistent vomiting, increasing drowsiness, any visual disturbance, or any new weakness or numbness in their limbs. If any of those happen, the risk of something expanding inside is just too high to manage at home.
This leads us straight to the decision point. CT imaging indications. When do we scan and how urgently?
The guidelines break it down into a rapidly developing emergency versus a high-risk but stable scenario.
Okay, so what gets you a scan within 1 hour?
The 1-hour urgency scan is for signs that suggest immediate mass effect. So that's any GCS dropping below 13, a GCS that stays below 15 2 hours after the injury, any focal neurological deficit or suspicion of an open, depressed, or basal skull fracture.
A post-traumatic seizure also gets you in that category?
Yes, and more than one episode of vomiting. The common thread here is instability or high clinical suspicion of something life-threatening that a surgeon might need to deal with right now.
Okay, and how does that compare to the 8-hour urgency category?
The 8-hour group is for patients who often appear mild, maybe a GCS of 15, but they have risk factors that increase the chance of a delayed bleed.
So this is about risk stratification.
Exactly. This includes being over the age of 65, being on anticoagulants like warfarin or antiplatelets like aspirin, a dangerous mechanism of injury like a big car crash, or retrograde amnesia that lasts more than 30 minutes.
So with the 8-hour group, we're acknowledging that even a seemingly mild injury could be a disaster for an older patient or someone on blood thinners.
Precisely.
Let's talk about concussion. We should probably define it clearly.
Right. Concussion is an alteration of consciousness or neurological function from a closed head injury. And critically, a full loss of consciousness is not a requirement. The key features are usually confusion, disorientation, difficulty concentrating, and amnesia. And the imaging is typically normal.
The big danger surrounding concussion, especially in sports, is this catastrophic thing called second impact syndrome.
It is rare, but the outcome is just devastating. It's a malignant brain swelling that follows a trivial repeat injury when the patient is still symptomatic from the first concussion.
What's the theory behind that?
The theory is that the first injury messes with the brain's autoregulation. So a second, minor blow, which would normally be nothing, hits a brain that can't control its own blood vessel tone. And you get this massive immediate vasodilation and swelling.
So the critical advice, the anchor here for any clinician treating athletes is,
If a player is symptomatic, they must never return to play, ever. Allowing them back on the field risks this catastrophic outcome.
and beyond the acute injury, a lot of people struggle with post-concussive syndrome.
A huge number. This is a persistent cluster of symptoms. Somatic ones like chronic headache and dizziness, and neurocognitive ones like memory problems, fatigue, difficulty concentrating, and often anxiety and depression.
This can be a really challenging area clinically, can it? Because the symptoms are so subjective.
They are, and the source rightly points out the additional complexity of secondary gain. The possibility of compensation claims or litigation can introduce a factor where symptoms might be, exaggerated or maintained. It's a fine line to walk.
Before we move on to managing severe trauma, we have to pause for a really crucial clinical duty, which is considering non-accidental injury, or NAI.
Yes, especially in children and vulnerable adults. Head injury can very frequently be the manifestation of physical abuse. We have to train ourselves to recognize the red flags.
And what are those red flags? What should immediately make you suspicious?
Delayed presentation's a big one. The caregiver waited too long. Injuries of different ages, old bruises, alongside fresh trauma, and specifically with head injury. Things like retinal hemorrhages, especially if they're bilateral, and bilateral chronic subdural hematomas in an infant without a clear, high-energy accident story are extremely suspicious.
And a lack of external signs doesn't rule it out.
Not at all. Severe neurological injury with no external marks demands rigorous questioning of the story. We have to make sure the reported mechanism is even possible for a child at that developmental stage, which we'll talk more about later.
Okay, we're shifting gears now to the front line. Managing the moderate and severe TBI patient, so a GCS of 13 or less. The protocol here is the systematic approach governed by Advanced Trauma Life Support, or ATLS.
The philosophy of ATLS in TBI is simple but absolutely unforgiving. You must ensure uninterrupted perfusion of the brain with oxygenated blood.
Because we're assuming autoregulation has failed.
We have to assume it's failed. So hypoxia and hypotension are immediate, deadly secondary insults. Maintaining oxygenation and systemic blood pressure is the first line of neuroprotection.
So it's A, BCA, airway protection with mandatory cervical spine control. This often means immediate intubation for a GCS of 8 or less.
Followed by B, breathing. Ensure adequate ventilation and oxygen saturation. Then C, circulation. Control any major bleeding. And it's really important to remember that profound hypotension in an adult is rarely from the head injury alone.
Unless there's catastrophic brainstem failure.
Right. So you have to look for the source of systemic bleeding in the chest, the abdomen, the pelvis, or, critically, a massive overlooked scalp laceration.
Which can bleed a surprising amount, especially in kids.
A shocking amount. The scalp is incredibly vascular. A medium-sized laceration can absolutely lead to shock in a small child.
And there's one quick, crucial check that has to be done immediately no matter what.
Check blood glucose. Hypoglycemia can mimic a severe neurological injury. It's easily reversible, and if you don't treat it, it's devastating to a brain that's already under stress. It's a 5-second test with massive implications.
Now, for the intubated comatose patient, the history is a puzzle you have to piece together from witnesses, family, or the paramedics.
There are 3 critical things we need to anchor from that history. First is the mechanism of injury. Was it a high-energy event, a high-speed car crash, a big fall? That immediately makes you think about multi-system injury and, crucially, spinal trauma.
And you want to know if they were hypoxic or hypotensive at the scene?
Yes, because those are established secondary insults that have already happened.
The second anchor is progression.
This means getting serial GCS and pupil checks. A drop in GCS between the scene and the hospital is the most dramatic evidence you can have that a secondary rapidly expanding injury, a surgical hematoma, is developing right now.
And the third anchor, which is now mandatory in every trauma history, is the medication alert.
You have to ask about anticoagulants, warfarin, DOACs, and antiplatelet agents like aspirin and clopidogrel. If that patient needs an urgent operation to remove a clot, correcting their coagulopathy is the single most time-critical step. You have to get the reversal agents or blood products moving instantly.
Let's circle back to the GCS score in this critical setting. You have to record the full EVM breakdown, not just the total score. Why is that so important?
Because 2 patients can both have a GCS of 10, but one might be E3V3M4, opening ice of speech, inappropriate words, flexing the pain, and the other could be E4V5M1, spontaneous eye-opening oriented speech, but no motor response at all.
And that M1 patient has a much worse prognosis.
Far worse, despite the identical total score. Always record the components and always take the best score you can elicit.
And we rely so heavily on the pupil exam as this external window into what's happening inside.
We document the size in millimeters, and we document reactivity, present, sluggish, or absent. As we established, a new, fixed, and dilated pupil is the signal of uncal herniation. It's an emergency.
Let's make this real with case study 1, the expanding mass. A 22-year-old male involved in a high-impact fall. Initially, GCS 15, pupils are equal and reactive. He's alert. 2 hours later, his GCS drops to 12. He's only opening his eyes to pain, and his right pupil is now sluggish and a bit dilated.
That is a 5-alarm fire. The question is, what structure is being compromised, and what's the mechanism?
The answer has to be uncal herniation.
Uncal herniation, compressing that right third nerve. It's overwhelmingly likely to be due to a rapidly expanding intracranial mass, an EDH, or ASDH, on the right side. That transient stability followed by the rapid decline is the classic sign of a mass hitting that decompensation cliff edge.
We should mention the pitfalls here, though. Not every dilated pupil is a herniation.
That's a good point. Direct trauma to the orbit, or a skull base fracture, can damage the nerve directly, causing a dilated pupil from the moment of injury. So you always have to integrate the pupil status with the GCS trend.
Okay, once the primary life threats are secured, A, B, C, C-spine, we move into the detailed head-to-toe secondary survey.
Right. Starting with the head, you meticulously inspect the scalp. A big, boggy swelling end of the scalp, a subgale hematoma, can hide depressed fracture underneath.
And you're looking for those classic external signs of a skull base fracture?
The ones you have to memorize. Our anchor signs are Battle's sign, which is bruising over the mastoid process behind the ear, and raccoon or panda eyes, that bilateral bruising around the eyes.
And you're looking for any leakage?
Yes. CSF or rhinorrhea, clear fluid from the nose or otorrhea from the ear. You also look for a hemotympanum, which is blood behind the eardrum. It's a strong sign of a temporal bone fracture.
And the most dangerous associated injury is often the one we forget about when we're so focused on the head, the spine.
This is non-negotiable. Up to 10% of patients with moderate or severe TBI have an associated C-spine fracture. You have to assume a spinal injury until it's proven otherwise. Even a modern CT scan can miss certain ligamentous injuries, so they stay in a hard collar until they're definitively cleared.
The final checks involve log rolling the patient.
You have to log roll them to feel the thoracic and lumbar spine, checking for tenderness or steps. You do a full sensory exam, looking for a sensory level which points to a specific spinal cord injury. And finally, a prorectum, or PR exam, to check anal tone and sensation.
And there's that one ominous sign in the trauma bay that instantly diagnoses a severe cord injury.
Priapism, a sustained erection. It's an involuntary sign that strongly correlates with severe spinal cord damage, even in an intubated, unresponsive patient. It's a sign that demands immediate attention to spinal stability.
So we've triaged and stabilized our patient. Now we move to the definitive diagnosis, identifying the enemy on the CT scan. This is where the specific shapes of the hematomas guide the surgeon's hand.
Right. Let's start with skull fractures. They divide into two main areas. You have vault fractures, which are on the dome of the skull. A simple, closed, linear fracture is usually just managed with observation.
The ones we worry about are open, comminuted so in multiple fragments, or depressed fractures. We need a clear definition of what depressed means.
The depressed fracture definition is anchored to the thickness of the bone itself. It's an inward displacement of a bone fragment by at least the thickness of the skull.
And why are they so dangerous?
Three major risks: a high risk of infection, late epilepsy from scarring on the brain, and a direct neurological deficit if the fragment is pushing into the brain. They almost always require surgical elevation and cleaning, especially if the dura is torn.
We talked about the external signs of skull-base fractures. What are the long-term problems we worry about internally?
They can cause specific cranial nerve deficits. A fracture of the cribriform plate can cause loss of smell. A petrous temporal bone fracture can cause facial palsy or hearing loss. And there's a risk of carotid or vertebral artery dissection, which can cause a delayed stroke.
And we have to reiterate that one huge safety warning.
Blind nasogastric tube placement is absolutely contraindicated if you suspect a skull-base fracture. There's a devastating risk of passing that tube intracranially through a fracture line. It's a never event.
Okay, let's anchor the three major hematomas based on their mechanism and how they look on CT. Let's start with extradural hematoma, or EDH.
EDH is the classic neurosurgical emergency. It's typically an arterial bleed, usually the middle meningeal artery, which gets torn by an overlying fracture of the thin temporal bone.
And that arterial pressure is why it expands so fast. The classic history is the key feature. The initial LOC, then that reassuring but ultimately treacherous lucid interval, and then the rapid neurological collapse.
On CT, the appearance is unique. The CT appearance metaphor is a lentiform or lens-shaped hyperdense lesion. It's biconvex.
Why that shape?
It's because the duramater is so tightly stuffed to the inside of the skull. It constrains the spread of the blood. The arterial pressure pushes inward, creating that convex lens shape. Prognosis can be excellent if you get to it fast enough.
Okay, now let's contrast that with the acute subdural hematoma, or ASDH.
ASDH is far more common, and it happens in two very different contexts. First is high-energy injury, where it involves tearing of cortical vessels and, crucially, significant underlying primary brain injury. These patients crash fast, often with no lucid interval.
And the second context?
Low-energy injury, especially in the elderly or those on anticoagulants.
Yeah.
This is often venous bleeding from strict bridging veins.
Anatomically, the blood collects in the space between the dura and the brain itself.
Right. And because the dura isn't adherent to the brain surface, the blood is free to spread out widely.
Which gives us that distinct CT appearance.
The CT appearance metaphor is a diffuse concave, or crescent moon, hyperdense lesion. It follows the contour of the hemisphere. And because it's so often associated with severe underlying brain injury, the mortality rate is tragically high, sometimes over 50%.
Now for the third one, chronic subdural hematoma, or CSDH. This one is often a diagnostic challenge because the injury can be so trivial or old.
It's very common in the elderly because of age-related cerebral atrophy. The brain shrinks, which stretches those bridging veins, making them incredibly fragile. The trauma causes a slow venous bleed that just accumulates gradually.
And the key to its chronic expansion is its unique pathophysiology, isn't it?
It is. The pathophysiology anchor here is osmotic expansion. Over days and weeks, membranes form around the hematoma, and the breakdown products inside the clot create an osmotic gradient, actively pulling water into the collection. It slowly gets bigger and bigger.
And because the blood products have had time to degrade, what does it look like on CT?
The CT appearance is usually a diffuse hypodense lesion. Hypodense means it looks dark or black, indicating old liquefied blood and fluid. Sometimes, if there's been a recent rebleed, you'll see areas of mixed density.
And the management is different because the clot is often liquid.
That's right. Simple burr hole drainage is often preferred over full craniotomy, because you can just wash out the liquefied contents easily.
Okay, let's quickly touch on injuries within the brain tissue itself. We see traumatic subarachnoid hemorrhage, or TSAH, a lot.
It's the commonest cause of subarachnoid hemorrhage, and it's usually managed conservatively.
And we also see cerebral contusions. These are essentially brain bruises.
Yes. Typically found near the irregular, bony surfaces of the skull base, like the inferior frontal lobes and temporal poles. This is the coup contre coup pattern injury at the point of impact, and on the opposite side as the brain sloshes back and forth.
Then there's the really high-energy diffuse injury, often with a prolonged coma, diffuse axonal injury, or DAI.
DAI is a microscopic pathological diagnosis. It's caused by widespread shearing forces from high-velocity acceleration and rotation that literally tear the axons, the brain's wiring, across huge areas. The clinical picture is often way worse than the initial CT scan looks.
And finally, arterial dissection.
This usually affects the carotid artery at the skull base. It presents with headache, neck pain, and then focal ischemic deficits, basically a stroke, due to clot formation. It's key to recognize because it requires urgent anticoagulation to prevent a much bigger stroke.
Okay, let's consolidate this section. EDH is arterial lentiform. ASDH is venous or cortical, crescent-shaped. CSTH is venous, hypodense, and expands by osmosis in the elderly.
And always use battle sign or raccoon eyes as your anchors for a skull base fracture.
All right, time for case study 2. A 78-year-old on warfarin presents with 2 weeks of gradual confusion and headache after a minor stumble. The CT shows a diffuse layer covering the left hemisphere, but this layer is gray. It's the same density as the brain tissue. What is the diagnosis, and what stage of evolution does that density represent?
Well, the history is classic CSDH. The fact that the layer is isodence, the same density as the brain, means the blood is in that subacute phase. It's roughly 10 days to 3 weeks old.
So the acute blood, which would be bright white, has broken down.
But the chronic fluid, which would be dark, hasn't fully formed yet. Yeah. And this is a major diagnostic challenge because that lesion can be incredibly subtle and easy to miss unless you're specifically looking for it. It requires a very high index of suspicion.
So whether a patient has a surgical lesion or a diffuse injury, the real battle for the brain begins in the intensive care unit. The focus shifts entirely to stopping that spiral of secondary injury.
We have to come back to the central problem. The vicious cycle of secondary injury. A raised ICP reduces your CPP. Reduced CPP causes cerebral ischemia, which leads to secondary brain injury. That injury causes inflammation and swelling, which further raises your ICP.
It's a physiological noose that just keeps tightening.
Exactly. Our entire ICU strategy is designed to break that self-perpetuating vicious loop.
And the first critical decision in that pathway is getting the patient to the right place.
Early discussion with and transfer to a regional neurosurgical center is paramount. The data consistently shows much higher mortality rates for severe TBI patients who are managed outside of specialized neuro units, even if they don't end up needing an operation. Expertise and infrastructure really matter.
Once they arrive, the primary focus is controlling that ICP. They're intubated and ventilated, not just for their airway, but as a therapeutic step.
It is. Intubation lets us precisely control their CO2 levels, which is our most potent tool for changing cerebral blood vessel tone. And as a temporizing measure, while we're getting them to the scanner or mobilizing the team, we use hyperosmolar agents.
Like mannitol or hypertonic saline.
Yes. They work by creating a huge osmotic gradient that pulls water out of the swollen brain tissue and into the bloodstream, causing a rapid, though sometimes transient, drop in ICP.
And how do we monitor that pressure directly?
We install an ICP bolt, or even better, an external ventricular drain, an EVD. The EVD is superior because it does two things. It monitors the ICP reliably, and it allows you to actually drain CSF to actively help lower the pressure.
What are the pressure thresholds that tell us we're losing the fight?
Any sustained ICP over 20 to 25 millimeters of mercury is strongly correlated with poor outcomes. And our goal for CPP is non-negotiable. We have to maintain it above 60 to ensure adequate perfusion.
And before reaching for the powerful drugs, what are the simple physical things we do?
Simple measures are incredibly effective. Elevate the head of the bed to promote venous drainage. Make sure the cervical collar isn't too tight and compressing the jugular veins. And we have to aggressively control any fever and seizures because both increase the brain's metabolic demand.
Let's look at the specific intensive care target parameters. These are the critical numbers that define neurointensive care.
First, PADOC O2. We aim for 4.5 to 5.0 kPa. We use controlled ventilation to keep CO2 low to normal. Hyperventilating them, pushing the CO2 much lower, causes vasoconstriction and lowers ICP, but if you're too aggressive, you can cause ischemia. It's a tightrope.
Okay. Then PaO2 greater than 11. That's just avoiding hypoxia.
All costs. Then MAP between 80 and 90. We actively infuse fluids and pressors to keep that MAP up to ensure the resulting CPP stays above 60.
And finally, electrolytes. The source specifies sodium greater than 140 and potassium greater than 4.
Sodium management is vital. We aim for the high side of normal sodium because a slightly elevated serum osmotic pressure helps pull water out of those swollen brain cells.
Okay, so what if those first-line measures aren't working and the ICP stays high? We have to escalate.
Escalation starts with increasing their sedation and analgesia, and then often adding neuromuscular paralysis muscle relaxants to stop any straining or coughing, which can cause ICP spikes.
And if all of that medical management fails, we're moving to the high-risk, last resort interventions.
These include inducing a deep, medically induced coma with high-dose barbiturates, like thiopentone. This massively suppresses the brain's metabolism and reduces its need for blood flow.
And then there's surgical decompression.
Surgical decompressive craniectomy. This involves removing a large section of the skull to give the swelling brain physical space to expand outward. While it's great at controlling refractory ICP, the big trials have shown limited or even absent benefit in terms of long-term functional outcome.
Let's talk about electrolyte imbalance, which you said is endemic in severe TBI. The pituitary gland is often the source of the problem.
It is. We need to anchor the three big sodium and volume disorders that come from pituitary or hypothalamic damage.
Okay, first, cerebral salt wasting, or CSW.
In CSW, the kidneys waste too much sodium. This leads to volume depletion. The patient is dry, and hypernatremia, low sodium. We treat it by aggressively replacing both salt and volume.
Second, syndrome of inappropriate ADH, SIADH.
SIADH is the opposite. It's excessive water retention. The patient is often normal or even a bit overloaded with fluid, but their sodium's low because it's been diluted. We treat this with fluid restriction.
And third, the other opposite problem, diabetes insipidus, DI.
DI is a failure of ADH secretion. The kidneys can't retain water. This leads to massive urine output, severe volume depletion, and hypernatremia high sodium. We treat this with fluid replacement and synthetic ADH.
And all this complexity is why we have to be so careful with our choice of fluids.
Hypotonic fluids like dextrose 5% are strictly forbidden in TBI. They have low osmotic pressure, and they will rapidly shift into the brain tissue and make the swelling worse. We only use isotonic or hypertonic solutions.
And the final major warning about medications, corticosteroids.
Despite their use in other types of brain swelling, like from tumors, routine use of corticosteroids like dexamethasone in severe TBI is associated with increased mortality. They are emphatically not recommended.
Okay, a few final points for ICU. Seizures. Who gets prophylaxis?
The risk is highly correlated with severity. It's low in mild TBI, but can be as high as 60% in severe TBI, with risk factors like an intracerebral hemorrhage or a depressed fracture. We give prophylaxis, usually with phenytoin, for the first 7 days in those high-risk groups.
And nutrition is vital.
Absolutely. The injured brain is hypermetabolic. We need to start enteral nutrition tube feeding within 72 hours.
And finally, we track recovery with the Glasgow Outcome Scale, or GOS.
Right. And it's important to understand that GOS-5, which is good recovery, means the patient is independent and can return to work or school. It does not mean they return to their pre-injury capacity. Subtle but persistent memory, personality, or executive function problems are really common.
TBI in children needs its own discussion. Their anatomy, their physiology, their management, it's all significantly different.
It really is.
Yeah.
Anatomically, children, especially infants, have a disproportionately large head relative to their body. This makes them prone to severe deceleration injuries and a greater risk of associated neck trauma.
And assessing their neurological status isn't as simple as just running the standard GCS.
No. For children under 2, we use the Pediatric Glasgow Coma Scale, the PGCS. The motor and verbal scales are modified to reflect their developmental milestones, differentiating between coos, cries, and words, for example.
And there's a key, almost unique clinical anchor in infants.
The Fontenelle. Palpating an open anterior fontanelle gives you a direct, non-invasive assessment of ICP. A bulging, tense fontanelle is a powerful sign of significantly raised intracranial pressure.
We also mentioned their vulnerability to massive blood loss from the head itself.
Yes. Unlike adults, their open sutures allow the skull to expand slightly, which means they can accommodate a much larger bleed internally. But that volume comes from their systemic circulation, and it can actually lead to hemorrhagic shock, something you just don't see in adult TBI.
Because CT radiation is a big concern in children, the imaging indications are much more stringent.
They are. They include criteria tailored to infants who can't tell you their symptoms, like a GCS less than 15 in a child under 1, a laceration bigger than 5 centimeters, or more than 1 episode of vomiting.
And we have to come back to the safeguarding priority. When a child presents with a head injury, non-accidental injury, or NAI, has to be top of mind.
Always. This requires a high degree of skepticism. The mechanism reported by the caregiver must be consistent with the child's developmental stage. For example, a 3-month-old infant cannot roll over or climb. If the story is that the child fell down the stairs, that history is developmentally impossible, and it requires an urgent investigation.
So the key takeaways for managing TBI in children
Are defined by their unique anatomy and vulnerability. They have large heads, a high risk of blood loss, and open fontanelles. Use the PGCS for infants, follow the tailored CT guidelines, and always remember that NAI is a primary diagnosis that has to be excluded.
We have spent a good amount of time in this deep dive, tracing the journey of TBI from the minute physiology of perfusion all the way through to specialized intensive care and pediatric considerations.
We cover that central conflict between the fixed primary injury and the modifiable secondary injury, anchoring the importance of keeping that CPP above 60. We saw how the Monro-Kelly rigid box explains that sudden catastrophic decompensation, and how that's signaled by uncal herniation and the full Cushing's triad.
We structured our assessment using the GCS, learned the critical triage points for CT scanning, and cemented those surgical pathologies using the CT metaphors. The arterial lentiform shape of the EDH, the venous crescent moon of the ASDH, and the osmotically expanding hypodense old blood of the chronic SDH.
And finally, we detail that intensive medical management, stressing the need to break that vicious cycle of secondary injury by controlling PASO2, MAP, and ICP, while managing sodium and strictly avoiding hypotonic fluids and routine steroids.
This conceptual path is really designed to give you a structured, sticky framework. We strongly encourage you to go back to the source Baily and Love, Chapter 28, to reinforce all these concepts and fill in the details.
And we'll leave you with this final provocative thought. We started with the staggering statistic that TBI causes long-term disability in 2% of the population. And we discussed how good recovery on the outcome scale doesn't mean a full return to function. So given the immense human and financial cost of long-term TBI care, and the fact that prevention is the only true cure for that primary irreversible injury.
Where should we put our resources?
Exactly. Should future public health policy prioritize these exponentially costly and complex ICU strategies designed to mitigate secondary injury? Or should resources be fundamentally reallocated to primary prevention, mandatory helmet laws, better vehicle safety, aggressive RTA campaigns, to reduce the initial trauma from ever happening in the first place? It's a question worth mulling over.
Until the next deep dive, stay curious and stay informed.